Okay, hey guys. So today we're going to do chapter 18, geriatric emergencies. We'll always get my computer working. There we go. So geriatrics, impact of age-related changes on assessments and care. There's a lot of changes between children, middle-aged, and elderly. Going to discuss some of that, how to interact with those elderly patients. So we're going to talk about patients with some of those special challenges too, how we recognize and report abuse and neglect. A geriatric patient is a patient who is older than 65 years. There's 52 million people were age 65 or older in 2018. I know that's a little bit dated. This population is exceeded or expected to double by 2060. The natural aging process results in a decline in functioning of all body systems. So we start to kind of wear down, and that's what we're really talking about today. Um, so we don't want to prejudge physical or mental capacity or condition of a patient just by looking at them. EMS responds to a bunch of calls that include or involve geriatric patients. You should conduct a complete secondary assessment on all patients because there could be underlying issues that aren't just obvious sticking out there, like in a younger patient. So, history taking super important here, knowing medications that these patients are on, and visiting with these patients or their family to get good information is really important. Two of the most socializing senses, uh, hearing and sight, they kind of deteriorate the older we get. So a lot of people will have hearing loss and sight issues as they age. Um, Driving and walking can become hazardous. Impaired vision and confusion often contributes to mistakes in taking medications. So we've got that polypharmacy, which is when you have a large amount of pills or medication you take every day. Um, so that's one of those little pill boxes where you put five pills on Mondays and five on Tuesdays and five on Wednesdays. That's why those are really handy and important. And it's important for us as first responders to find those and make sure that, hey, today's Monday, but Monday, Tuesday, and Wednesdays are all gone, because that could tell us what's going on there. Some older people or adults require the use of hearing aids. People with certain inner ear disorders are more prone to poor balance and falls. It affects our equilibrium. Um, so sometimes they're more wobbly. Communication. So be certain an old person can hear and understand what you're saying. Identify yourself and speak slowly and clearly. So, and we're going to get into this, but I'm going to go ahead and get on my soapbox early. Don't just walk in and start yelling at an old person because you think they're deaf or because they say or what one time. Um, and we're going to talk about kind of how to approach them, but we treat them with respect. They are our elders. So, right here, do not shout. Ask the patient if he or she can hear you. Speak directly into the patient's ear or maintain eye contact or lip reading. Um, I'm in my 40s and I am like 93% deaf in my right ear, I think is what they told me. I'm not that old and I read lips all the time because I can't hear. So, once again, you can't just judge a book by its cover. If you are still having difficulty communicating, offer paper and pencil, use sign language if you know it. If you know sign language, that's awesome. I don't. Some of the other things we can do is slow down and just use hand gestures, point at body parts. Um, Just like any other patient, we're going to be at their level. We make that eye contact. We stay calm, they stay calm. There's ways to communicate. Sometimes it just takes a little bit longer to do so. Um, so when we're dealing with the visually impaired or the blind, look for signs indicating visually impaired during your scene size up. Once again, our scene size up, we're looking for things, right? We want to notice things about the patient, about the surrounding area, the house, wherever we might be. Um, Eyeglasses, a cane, a service dog. Ask questions when you're dealing with, when you see these things, ask questions. A visually impaired person may feel vulnerable during an emergency scene. So tell the patient what is happening, identify noises and describe soundings, find out the person's name and use it, provide emotional support, keep eyeglasses with the patient if possible. So, and really big, and you guys have figured this out by now, on telling your patients what you're doing. I don't care if they're visually impaired, hearing impaired, or if they are perfectly healthy, middle-aged, younger, it don't matter. We talk to our patients. We verbalize everything we do. Whether we're in class or we're in the back of that truck with a patient, we verbalize every single move we make. And that's part of building that trust. That patient's name, ask them what they prefer to go by and use it. Provide that emotional support. It's not your emergency, it's theirs. We are there for them. Let's see. Techniques for communicating. So identify yourself. That's as simple as, hey, I'm Evan. I work for X, Y, and Z. Look directly at that patient. So we make eye contact. We've talked about that. Speak slowly and distinctly. Explain what you are going to do in clear, simple language. We don't use terminology. We don't try to sound smart just so we look good. We talk to them just like we would our family. We talk to them just like we would our best friend. And then listen to that patient. Let them tell you how they feel. Don't try to lead them on. You ask them, how do you feel in your words? Because we can actually learn a lot if we are quiet for a minute and listen. Show the patient respect. Do not talk about the patient in front of the patient, and then be patient. So you can ask questions if that patient's confused or something. Yes, it's good to ask family or friends or there, but we need to try our best to communicate with that patient. We are building that rapport. If they're able to answer our questions, that's who we need to talk to. There are scenes where we go in and daughter or son or husband, they try to answer all the questions for them. And there are times when you have to go, hey, I need them to answer for me, please. So don't be afraid to do that and be patient. Sometimes it takes a minute to get the answer. Sometimes the way we ask a question isn't clear enough. Sometimes we can ask the question in a different way and get an answer. So just be patient with them and sometimes take time. As a person ages, several changes occur to the musculoskeletal system. So muscles lose strength. We know that. Disc between the vertebrae become narrow, which can cause loss of height, curvature of the spine, and loss of flexibility. Bones in the skeletal system lose their strength, and older people experience some loss of balance, which we talked about a little bit. And part of that can go to that weakening of muscle, or the curvature of spine, or any of that. They can become unstable. These changes result in an increased incident of falls among the older patients. So falls result in an increased risk of brain injury because blood vessels are more fragile and the brain gets smaller as a person ages. So that is something you might want to remember and consider. Uh, yeah, as a person ages, movements become slower. Lend a helping hand or supporting arm we don't want to so much take this person's independence away, but if we're there, we're going to do everything we can to help them. That's why we do what we do. So don't be afraid to assist someone on or off duty. Um, Allow enough time for the patient to move safely rather than try to rush them. If they're not dying, give them that respect of letting them go at their speed. So fractures occur frequently in the geriatric population because loss of bone density often results in osteoporosis. Fractures of the wrist, spine, and hips are particularly common. Why is that? It's because of falls. They get uneasy or imbalanced, they fall, they try to catch themselves, they break their wrist. They can fall, injure their spine, and the hip is a big one. Geriatric patients may have a reduced awareness of pain. Sometimes these older people who have a broken hip and it's obvious, you say, "What's your pain? 0 to 10?" And they'll go a 4, where you or me might go, "We're at a 13." Um, so just keep that in mind that sometimes they can handle that pain because their receptors aren't as receiving as they used to be. Hip fractures are a common result in osteoporosis. It occurs most often in older women. Injured legs is usually, but not always, shortened, and in relation to the other leg, toes of the injured leg are externally rotated. So if we go on a possible broken hip, a fall with hip pain, what we want to do is we want to look and make sure those legs are the same length, and make sure that if it's shorter, it will also be rotated. So shortening and rotation of the leg is a telltale sign of a broken hip. Splint patient transport properly. So, okay, I didn't know where it went into. So, splinting and transporting a possible broken hip. So the pelvis and the hip are pretty scary areas because we got those femoral arteries. And we've got that pelvic girdle that can hold a ton of blood if we have an internal bleed, if we've hurt something down there. So what we want to do with a hip is I prefer a full body vacuum splint. We can use a scoop stretcher to get under them and move them. If we have it, a pelvic binder or even a sheet or a blanket, wrap it around them hips and then tie it in a knot tight. I mean, it will pull everything together and just hold it. It won't let it sit there and move. Um, you can also take a KED, flip it upside down, and use it to cinch around that pelvis and those hips, and it will hold everything in place, and it helps with pain. And your patients you'll know it because once you put that on, they're going to go, huh. And it's just going to take some of that pain away from them. But make sure that we support that hip or those leg fractures or whatever before we start trying to move that patient. We want it as secure as possible before we start moving. Conditions that may occur with advancing age. This is everything we've already talked about. Medical considerations. So as people get older, they are generally less able to fight off diseases. Their immune system become less effective. They are not able to cough as effectively, so more junk gets down in those airways. And they have an increased difficulty handling secretions. They're unable to clear those secretions. Cardiovascular disease are conditions that affect the heart and blood vessels. So we know cardio is heart, vascular is going to be our vessels. As people age, blood loses its ability to speed up the heart, or sorry, the body loses the ability to speed up the heart contractions, and blood vessels become stiffer and narrower by fatty deposits. These changes increase occurrence of the heart attack, angina, or congestive heart failure. So we build up our plaque in our arteries. It becomes harder. Blood flow does not move as well. And our heart, you think about it, let's say we take a 75-year-old male or female whose heart rate, let's say it's 70 to 120 for the last 75 years, that heart's getting tired. That pump is wearing down. So it's unable to fight the pressure that's needed to pass through those hardening arteries. And that's where the heart slowly starts to give up. It slowly starts to break down. And we get those heart attacks, so that chest pain, so that angina, and that congestive heart failure can form. Strokes and uh, abdominal aortic aneurysms, or AAA, are two common conditions related to problems with blood vessels. Um, so we know strokes, we have ischemic stroke or hemorrhagic stroke. So ischemic is lack of blood and oxygen. And then we have, yeah, I just said it, hemorrhagic stroke, and that's where we have a bleed. Um, AAA is the separation of the aorta. Um, So that aorta can actually get a split in it. It begins to fill that void begins to fill with blood, and then we can rupture that aorta, and that's a bad deal. Um, Geriatric patients may not have classic signs and symptoms. So older patients have a decreased awareness of sensation of pain. We talked a little bit about that. Treat older patients with a high degree of suspicion. This is where our history and our vital signs are going to be key. They might not be able to tell you how bad it truly is. So we have to use our knowledge. We have to look at signs and symptoms. We have to take our history and go, yeah, this person has high blood pressure. Yes, they take medication for that, or they're on a blood thinner, and they just had a major fall, and now they're not acting right. We got to take those kind of things into consideration. Um, and then our vitals. Learn your vitals. Learn what's good. Learn what's bad, because they are key to finding a lot of problems. As a person ages, um, sorry, we're in the respiratory diseases. As a person ages, those alveoli lose some of their elasticity. Muscles associated with respirations become weaker. So once again, just like we talked about the heart and the 75-year-old, so we breathe most of the time 12 to 20 times a minute, right? I'm 75 years old. The elastic in my alveoli, so those are those little sacs in your lungs that when you take a deep breath, the oxygen goes in, carbon dioxide comes out, cellular respiration takes place. Okay. Yeah. So after 75 years of that little balloon blowing up and going down, blowing up, going down, um, the elasticity is going to give up. So if you took a balloon and you blew it up 20 times a minute for 75 years, that balloon at some point is going to give out, right? So that's the same thing that's going on inside our alveoli. And then our respiratory system, the muscles, and our tissues, like when we take that breath and our chest cavity expands so our lungs can expand. All of that has stretched over and over and over our entire life. And so it begins to wear out. And so it's not stretching, or it's not rebounding as well as it used to. And so the respiratory system slowly begins to suffer. Two major types of respiratory diseases: there's chronic respiratory disease and acute respiratory disease. So chronic is long term, chronic illnesses, chronic respiratory disease, whatever. Chronic means it's long term. Acute is it happens suddenly. Patient with chronic obstructive pulmonary disease, or COPD, may live with this condition for many years. That's why it's chronic, it's long lasting. A cold or other respiratory infection can result in a medical emergency. Acute respiratory disease strikes quickly, like pneumonia is common in older patients. Physician should examine the older patient who has congestion and a possible fever. Want to catch these things early. Um, Get that SpO2. Don't be afraid to give some oxygen. Um, let's see. And we don't want refusals. I know um, sometimes it's hard, but we need to try to convince these patients to go to the doctor. And once again, every chapter I got to say it. If you know your stuff, educate the patient. Why do you need to go to the doctor? Because X, Y, and Z. Um, you're congested, you have a slight fever. This could actually turn into pneumonia. And we don't want that. That's hard to recover from at the older age. So let's go ahead and go get checked out. Maybe we can get you some antibiotics or something. It's that simple. You don't have to sound like a doctor. Just have a rough idea. Don't lie to your patient, but have a rough idea what you're talking about. If we educate them, they trust us, then usually we can get them taken care of. Because if you don't, then I'm going to tell you, you're going to see this person in 3 or 4 days, and the situation's going to be a lot worse. Treatment, carefully examine the patients, secure an accurate medical history, past and present. Treat the patients presenting symptoms, arrange for transport. So it never changes, guys. We do an assessment from top to bottom. These are a medical assessment. So we're going to focus on the main problem. And then we're also going to kind of in our secondary, we're going to check other body systems. Why we listen to those lungs? Let's listen to that heart. Why we're sitting there touching their skin? Are they hot? Are they pale? Are they cool? Are they clammy? Are they sweaty? Ask them, have you had normal bowel movements? Are you having normal urination? Are they making sense when they talk to you? Are they following you with their eyes? We do all of this in a matter of a few seconds. But if you think about your skills, your medical skill sheet, you do everything on that sheet. It just takes a matter of seconds because it goes quick with the person. So that medical history, I don't need to know that you had a splinter when you was 5 years old. What I do need to know is that last year you had a stent put in. I need to know that 4 years ago you did have COVID. Present. Why are you on blood pressure medication? What's your blood pressure normally around? Are you a diabetic? Are you taking your medications like you're supposed to? Do you have those medications? Can I look at them? Those are the kind of things we want to do. Cancer. So cancer can strike any part of the body. Patients call for help when complications from cancer result in acute pain, shortness of breath, shock, some other medical condition. Provide support and transport. Remember that cancer can happen at any age, though. I know we're talking about geriatrics here. This is where your history comes in. I'm not a cancer expert. I don't know a lot about it. But just be mindful that they are going through a lot with this. Altered mental status, common cause of decreased responsiveness in older patients, lack of adequate blood to the brain, low blood glucose levels, and hypothermia or shock. Assess patient, provide treatment according to signs and symptoms you note. So remember, blood glucose that's a vital sign. If I walk into a person's house and they are altered, I'm going to take a blood glucose right off the bat. Are they on home oxygen? Are they using it? Are they puffing a cigarette at the same time their nasal cannula is running? These are all things that we can look at. Hypothermia. I know that's cold. Hypothermia can also refer to shock. Are they in some sort of shock? So those are the things we really need to look for on that. Medications. So many older people take a large number of medications every day. They may see several doctors for different conditions. Some medications may interfere with actions of other medications or cause adverse side effects. They may not take their medications as instructed. Determine which type of medication the patient takes. If the patient is being transported, bring medications to the hospital. So That polypharmacy that I keep talking about, that is when they take several medications every day. Um, and it might be from other doctors. And if at any time another doctor doesn't catch or the report doesn't come in on time and they give a medication that's going to react to a different medication, we might get a call. Um, so on those, do your history, take those meds with you, and get your vitals, that baseline set of vitals, and let's treat the patient's signs and symptoms. You don't have to know every medication that's out there. Uh, when I went to school, that scared me to death because I'm like, I can't learn all that. You don't have to. At this level, we just need to know the basics and take them with us to the hospital. And you can ask them, hey, what do you take this pill for? What do you take this pill for? Um, and sometimes that's a good way to learn. Infections and sepsis. So, infectious diseases are illnesses that are caused by bacteria, viruses, and fungi, may affect different body systems or different organs of the body. Older people have weakened immune systems. Signs and symptoms vary, but common signs and symptoms include like fever and fatigue, coughing, muscle aches, diarrhea. I'm going to go ahead and jump ahead and say if we've got some of that, we probably got some dehydration. Um, so once again, we treat signs and symptoms and we follow our assessment. Sepsis is a severe, potentially life-threatening complication of infection. Occurs when the chemicals are released into the bloodstream as a result of an infection. Triggers an inflammatory swelling, response without body or throughout the body. Most common in older adults and people who have weakened immune systems, can progress to septic shock and death. As an EMR, keep this patient comfortable. If you have oxygen, you might apply some oxygen. Go ahead and get a temperature on them and let's find out what their temperature is. Let's check, do our vitals. For these patients at EMR level, there's not a lot you can do, but comfort measures and vitals and go from there. Give a good report when EMS arrives. If an older patient shows signs and symptoms of infection, he or she should be evaluated by a physician to rule out possibilities of an infection or sepsis. So this goes back to educating those patients. My daughter called, I don't want to go, I just have a cold. Well, 75-year-old me, you need to convince me that that fever and the signs and symptoms you're seeing could lead to something worse. Don't scare the patient. Oh, you're going to die if you don't go. You can't do that. But you can educate them on, look, this could turn into a respiratory infection. This could turn into sepsis. The signs and symptoms are pointing that way. Let's just go get checked out. Patients who require long-term care. Many patients with chronic conditions are now treated at home by nurses or family. A variety of complex medical devices are used with these patients. And that's true. There are a lot more home health people out there. Or family takes care of them, takes them into their home. But you might run into some of these medical devices. You don't have to be an expert in them. You just kind of need to know what they are. These people who are at home or with home health, they're going to know how to operate this machinery. And they can walk you through just about anything. So you're going to run into ventilators, oxygen enriching devices, surgically inserted breathing tubes, monitors. A patient with certain heart conditions may have pacemakers or automatic defibrillators. Tubes inserted into the patient's arm, neck, or stomach may provide fluids or food. Catheters may drain urine from a patient's bladder. These patients often take a wide variety of medications. So once again, collect the meds, take them with you, get a good history. Why do they need these machines? Don't just assume anything. Ask questions. Here's a couple pictures. So on A, you've got a ventilator, and he's got a stoma right there. Got a feeding tube going directly into the stomach. Syringe hooks up here, and it pushes food directly into. Remember your roles in EMR: assess immediate problem, take appropriate steps to provide care within your scope of practice. Do not get overwhelmed or distracted by complex equipment. Don't ask questions. And if you're unsure and they can't answer that question, just stay with them until EMS arrives. Question the patient and caregivers. In most situations, you need to stabilize patient for only a few minutes until more highly trained EMS personnel arrive. Depression. Okay, so we're going to get into this. For elderlies who live independently, estimate 1 to 5%. Rate of depression rises significantly with loss of independence up to 13 to 5 or 13.5, and then more common in women than men. Contributing factors: living in a nursing home or living alone, loss of a spouse or close friend. And we are faced with people who family has told them, if you get sick one more time or if you fall down one more time, we're putting you in a home. And then it happens and we show up, they will fight with us. They won't want to go with us because they're going to lose their independence. They're depressed, they're angry, they're sad. Um, it's like being an adult, but being treated like a little kid. You're told you can't be trusted anymore. We have got to slow down as first responders and consider the mental side of this for those patients. It's extremely depressing for them. It's sad for them. Um, Cases of my own where we went on the same person multiple times. I mean, like every day we were going 2 or 3 times. And I finally had to call family and go, look, we got to do something. Um, he's not gonna survive this way. And the next day they put him in a rehab home. Um, or not like rehab, but like a rehabilitation for I don't know, physical therapy to strengthen him and all that. Anyway, point being, I felt horrible for days because I was responsible for taking that person's independence, and it absolutely haunted me. The man finally got to come home. He did great for a couple more years before he finally passed away. But we need to take into account that we're there for the best betterment of the patient. I'm not saying don't transport. I'm not saying that. What I'm saying is we just need to remember that, yes, we're there to take care of them and help them, but don't be surprised if they're depressed, if they become angry, if they argue or put up a fight, um, because they don't want to go to that nursing home or that uh, assisted living center. And then loss of a spouse or close friend, they might have known these people their whole lives. And then all of a sudden they're gone. I think most people have lost someone close to them and knows that pain. So keep that in mind. That can cause major depression too. Contributing factors: so declining health, chronic health conditions, or terminal illnesses. Be alert for signs and symptoms for persisting feelings of sadness and despair. If you observe signs of depression, bring them to the attention of the EMS providers or other medical professionals. Um, just be patient, be kind, listen to them. Older men have a highest suicide rate of any age group in the United States. Older people choose more lethal means, resulting in more deaths from suicide in this group. Um, so that's crazy to me that the older generation, especially men, they perform more lethal means, and they have a higher suicide rate. Um, Factors that contribute in this problem is physical illness, especially terminal ones, uh, loss of loved ones, or alcohol abuse. Listen carefully to patients and be alert for indications of hopelessness, depression, or attempts at suicide. If you suspect a patient may be considering suicide, arrange for transport. Don't just assume, but if they're throwing hints out and they're saying certain things and you're kind of like, maybe, just let EMS know, so that we can kind of keep an eye on it, and then maybe we can let the hospital know. Pattern of decline in mental function. So dementia, sorry, is a pattern of decline in mental function marked by impairment in memory and may result in a decrease in reasoning, judgment, comprehension, ability to communicate verbally. 20 to 40% of people older than 85 have some form of dementia. Causes of dementia are those small strokes, those TIAs, hardening arteries, and it can be hereditary. Alzheimer's disease, most common type of dementia, chronic degenerative disorder that attacks the brain and results in impaired memory, behavior, or thinking. Alzheimer's is very sad and depressing, so don't be surprised if you have to deal with emotional family. In terminal stages, patients may be unable to walk, lose control of their bowels and bladder, and become unable to swallow. When caring for the patient with dementia, speak clearly and use patient's name. Let patient know what you're doing at each step of your assessment and treatment. We do that with everyone. When caring for a patient with dementia, you may need to rely on family members or caregivers to provide a medical history. Use a kind and caring approach. Slow down, speak softly, make that eye contact, talk to the patient, but if family's there, then you need them communicating with you as well. So hospice care, a hospice is a healthcare program that brings together a variety of caregivers to provide physical, emotional, spiritual, social, and economic care for patients who have terminal illness and who are expected to die within 6 months. Yeah, I don't want to go any deeper into that. We could, but pain relief is provided through oral medication, special pain relieving patches, medicine placed in the mouth between the gum and the cheek. EMS is usually called when patient experiences unexpected problems such as shortness of breath. Um, yeah. So if you go on EMT, we will go into hospice a little bit deeper and we'll explain some of the do's and don'ts or should and shouldn't haves, but we won't right now. Advanced directive. So document that outlines care patients want to receive if they are not able to make their own medical decisions. Some people um, they don't want a feeding tube, but they do want to be given oxygen or they do want pain relief. So it's a written order on what we can or what they would like if they can't make the decision at the time. Um, May include a DNR or do not resuscitate order. A DNR order is a request to withhold CPR and other life-saving measures if a person's heart stops or if he or she is not stops breathing. So that 99-year-old at the nursing home who is bedridden and has absolutely no function, I don't know the right word. Um, the family and the patient might sign a DNR. Hey, don't try to bring me back. I'm 99 years old and there's no need for it. That DNR has to be present. and it has to be signed. So you have got to be handed a paper copy of a DNR for it to be valid. The MOLST medical orders for life-sustaining treatment. It's important that you know the regulations concerning these documents in your state, so know your protocols, know what you got to do. If you cannot determine whether an advance directive is valid, begin appropriate medical care and leave questions to the physicians. Older adults who are physically weak or mentally compromised are at a higher risk of abuse by the spouse, family member, friends, or caregivers. Elder abuse may be physical, sexual, emotional, or financial. Signs and symptoms of abuse is bruising, burns, trauma in the genital area, and signs of neglect. Signs of neglect can be not proper clothing, bad living conditions, um, no food in the house. That can all be signs of neglect. If you suspect abuse, report to authorities. Many community-based programs assist in supporting geriatric patients who need physical assistance, nutritional support, or emotional support. We're going to back up a few slides. We all know what spousal abuse is. Family members and friends. These people can be abusing these patients, and any of these people. What I really want to get at is the physical, sexual, emotional, and financial. So physical, we know it's a physical abuse. Sexual abuse, I think we all understand that. So the emotional, that turns to the daughter or the grandson or whoever. You're just wasting my time. Why do I waste my time taking care of you? You're not good for anything. Um, I don't even know why we keep you around. That's emotional abuse. Um, and then financial abuse is maybe they're in charge of this person's bank account. Maybe they are going and drawing money out of an account because they have power of attorney. They have financial power of attorney. Financial abuse is when they are taking advantage of. Summary, we're not doing the summary. So when caring for an older patient who is hearing impaired, you should speak very loudly so that patient can hear you. Speak directly to the patient's ear and maintain eye contact so they can read your lips. Assume the patient can read lips or just don't communicate at all. So we want to speak directly in that patient's ear, but maintain eye contact for lip reading. Fractures occur frequently in geriatric patients due to a condition that weakens the bone that is known as, well, syncope is fainting, dementia, that's mental, and dislocation that happens at a joint. So osteoporosis is a condition that weakens bones. Now, which of the following statements regarding suicide in older adults is the most accurate? This is the one that I said blows my mind. So it's older patients tend to use more lethal means than younger patients. Thanks for sticking with me on another one. I will catch you on the next one.